thanks everyone for being here, firstly, and I also would like to thank Heidi for organization of this session today. I'm really looking forward to our further discussions we may have later on. So I would like to give you a brief overview of what I will be talking today. So firstly, why what we do is important, and definition and the scope of the periodontal diseases. And also, where are we now? So what do we use in the current diagnosis of the disease? And what are the drawbacks of, what are the challenges as a clinician we face every day? And also, what is on the horizon? So what are the emerging diagnostic platforms may come in the future to our clinics? Periodontal diagnosis, and including the classification of the disease, has been an active area of investigation because of evidence suggesting that multiple forms of disease exist. And there is also unequal risk between the individuals, so not everyone prone to disease, despite they may carry some of the risk factors. And also disease is episodic, so the disease doesn't progress in linear way. So therefore we may need better diagnosis and better classification of the disease. And this classification is the latest one, which was done in 1999 by American Academy of Periodontology. So it's telling us that there are at least 8 different types of disease, and the most common ones, so to go back, that the gingivitis, chronic periodontitis, and aggressive periodontitis. And only difference between gingivitis to periodontitis is anatomical. So if we look at the gingivitis, inflammation is defined to the gingival tissues, whereas in periodontitis, the inflammation spreads deeper and affects the two supporting tissues, including alveolar bone and connective tissue attachment. So what is the burden of this disease? Despite oral hygiene improvements, it seems that the disease still remains, and especially in the severe form. And this data is coming from, published in 2014, but the data was accumulated in 2010. What this data, meta-analysis of already published work, is telling us that the periodontal disease, severe form, severe periodontitis, is the among 6 most prevalent chronic conditions worldwide. And this reflects in the number, more than 700 million people are affected, and in the percentage this is around 11%, despite there are differences between the regions or between the countries. So approximately 31 countries was assessed. And you can see here the numbers, that the percentage was given in the numbers is changing between 9 to 20%, above 20%. Sweden has been really pioneer in the oral hygiene practices, and we can see the data from Sweden that when the people start brushing their teeth, cleaning their teeth, flossing, and the forms that what we have as a mild form, gingivitis, and the mild periodontitis, is here reflected in the green and the red, was declined over the 30 years of period. So that those patients were follow-up, and this data is coming from Huguson et al. In 1998, and the latest one was published in 2005, telling us that indeed we can control the mild forms of disease. But the purple line here, this was the disease considered clinically as severe periodontitis, so this was the severe form, and we can see that there was an increase in the first 10 years period, and it remained still the same. So approximately around 13 to 15% of population in Sweden still have the severe forms of periodontitis. So for that population, we still need probably better treatment modalities rather than simply removing the dental plaque, simply removing what we think is etiological agent, and also probably better diagnostic tools to capture them early so that the disease does not progress into the severe form. And the terminology, what is diagnosis? So the diagnosis is a Greek word, is coming from diagnosis, to discern and to distinguish disease from signs and symptoms from non-disease. And the diagnostics refers to the instruments, procedures, and the technologies that used to diagnose the disease. So anything can be a diagnostic tool. For example, taking blood pressure and taking a pulse is a diagnostic tool, to ranging to measuring the blood pressure, and the measuring a marker in the blood is still a diagnostic tool too. So we will discuss how this is in the field of periodontics later on. What an ideal diagnostic tool should have, including in the periodontics? Non-invasive, so no one likes to be getting a needle into their body. For example, taking a blood is an invasive way of collecting information, and should be simple, so it can be applied by patient itself or by a non-professional who doesn't know how to do it. And the fast, so time is very important, and objective. So it should not be a subjective tool. And also specific and sensitive. So it should be specific enough to detect the disease and sensitive enough to differentiate the disease from the health. So the positivity and negativity in health or disease. And also reproducible. So if I do the test, it should give the same result. If someone else does the test, it should give us the same result. So it should be reproducible and should not be affected conditions around the test or the person who is doing it. And it should be safe. So that safety is, of course, the first any test that we are applying to our patients. So what happened over the years in the field of periodontal diagnostics? I think it's very important to see that many pioneers in our field were ahead of their time and left us with a great inheritance, so which we need to stress the value of this information and use it, despite what the ancient Greeks were doing back then may not be applying today or may have changed, but gives us the clues about how this information was used and how this was developed. So when the Greeks, ancient Greeks, knew nothing about the nature of periodontal disease. So if we look at the Hippocrates scripts, what we see that there is a disease in the oral cavity, and it can be diagnosed or found by its color and the bad breath. So that Hippocrates named this as an evil malodor. So basically, disease was diagnosed, what could be seen, what could be smelled, even tasted. And then later on, the field has progressed. Of course, the understanding of disease has progressed. And then there was an era where periodontal disease was diagnosed with what could be seen plus what could be measured. So we got into field some diagnostic tools, and you may know this guy. This is the Black, mostly known his work in the restorative dentistry, but he was the pioneer to use periodontal probe, which is still the current diagnostic tool in the field, and even design his own probe. So we started measuring the tissue loss in the field as an indicator of the disease. And then later on, there was an era where histopathology was governing the field, so we start to understand the disease at the macroscopic level, so how the lesion was made, which cells were there. But despite that, this era led us to understand the disease pathogenesis a lot and helped us to classify the lesions of periodontal disease, which did not have practical approach which can reach to as a diagnostic tool, because to do histopathology, you needed to remove the tooth and the tissue together, which is not a good diagnostic tool and very invasive, so it cannot be practically used. And then later on, in the mid-80s, there was a big challenge in the field to question current diagnostic methods, which was the clinical measurement of the disease by use of probes. And then the field has progressed. We have moved to infection and the host paradigm time, where the disease was understood as initiated by bacteria, but inflammation, what we see on the corresponding tissues, was a result of the inflammation. And this, of course, reflected in the methods that we start detecting the disease. There were a lot of tests, biochemical tests, and even some tests as a chairside test, which reached to the dental chair came into the market, but which was unfortunate that despite there was a lot of research ongoing, there was a lot of tests came, and even FDA, Food Drug Administration in USA, was approved. This test disappeared from the market and not much used in the clinical practice. But still, this does not disvalue of the disinformation. It doesn't mean that this information which was there will not reach one day to the clinical practice. So let's look at the periodontal probe. All of you who are dentists here, who are periodontists here, very familiar with this tool, which is a diagnostic tool. In the millimeter increments, so the word is coming from Latin, probo means to test. So we can measure by this device how much tissue loss was done in the periodontium. But despite it is a mostly used device, a mostly used tool in the clinic, it has its own drawbacks. One of the drawbacks that this tool is time consuming. So we have to assess 168 sites in the mouth if we want to get a whole picture of periodontal disease status in the mouth. So we are not the only one who questioned this. There was even a study published in 2012 in the Journal of Dental Research, which looked at the data and the same patients. If we were probing those patients with the two-size assessment, which is mostly used in the epidemiological studies because too time-consuming to assess 168 sites, the prevalence of this disease in that population was 19.5%. When the dentist assessed the 3 sites, so they increased the 1 site more in the same patient, and the prevalence have increased to 27%. When the full mouth was assessed, and then the prevalence was 47%. So what this data was showing us that the clinical partial mouth screening leads to underestimation of the disease. So we do miss a lot because we don't, because of time restriction, we do not assess to all the sites. So we need much faster screening tools which can tell us if our patient has a disease, and then we can go do a more detailed screening in the dental chair if needed. But this is not the open issue in the field of periodontal diagnosis by use of the clinical measurements. That another issue that the periodontal diagnosis is made based on the clinical measurements, including probing of the pocket and the clinical attachment level and the x-rays. What we are looking at the past disease. So this doesn't tell us that what is going on now. So we are not actually looking if the disease is active or non-active, and basically looking at the history of disease, which diagnosis should not rely on the history, should be telling us what is happening today. And also, our current diagnosis and the classification clearly not looking at the true nature of the disease. We have different forms of disease. You have seen in the first slide that 8 different classifications, but paradoxically, all these diseases coming into our clinic with the same clinical presentation. Therefore, we treat them in the same way. So possibly our treatment modalities are not effective because we do not diagnose the disease based on this nature. So to understand the nature, we need to do more research in the pathogenesis and etiology to know the better the disease, better the diagnosis, and better the treat the disease. So what the future may hold. So what we want to do now, and all our predecessors have been doing also, that we want to move away from the probing the destroyed tissues to the biologically defined disease. So how can we do this? We have tools to allow us, firstly, characterize the events that are taking place in the disease in a given periodontal lesion. And this is a discovery, so we can find the molecules, we can find the proteins, we can find the genes that really governing the disease. Then we can go and use innovation and reach them on the dental chair and try to biomarker-based evaluation of periodontal disease. To coming next, what is a biomarker? Which has been defined and changed the definition several times, but this definition that I am giving to you is coming from 2001 Biomarkers Definition Working Group, And what they say that the biomarker is a characteristic that is objectively measured and evaluated as an indicator of a normal biological process, pathogenic process, or a pharmacological response to therapeutic intervention. So anything which is measured, an indicator of disease, can be a biomarker. What technologies are available to us to find the biomarkers? We are in the era of omics, where we can look everything in more holistic manner, whereas in the earlier times we had the biochemical tests, immunoassays. These were specific tests which we were looking for a specific marker. But in this era we have genomics, which can tell us the whole DNA content. We have transcriptomics, which are looking at the gene expression in the more holistic manner, and the proteomics that can tell us all the proteins in a given sample. Why I have put genomics much lower than the proteomics? Because the gene and the DNA can tell us about the future. So the DNA is a good storage media, but all it comes to, in the next stage, it comes to the gene expression, which is mRNA, is a great messenger. So it transfers the message from the DNA. But the proteins are the actual workers of our body. So if we want to find a biomarker, and the proteins should tell us at the moment what is happening, because they are at that moment working and communicating with each other. That's what our research, my research, is mainly focusing on, the finding proteins that could be indicator of the disease. When we PubMed, where can we search the biomarkers of periodontal disease? Of course, the first place to look what is already done, what is already known, and the PubMed is our great library. We can type biomarker and periodontal disease. That's when I did my presentation. What I have found that there are more than 2,800 publications with these keywords, and more than 273 was published in 2016 alone. This shows us that the biomarker research is in its peak. Really, a lot of people are doing and trying to find the biomarkers for periodontal disease. So we are on the right track. And one can go and look all the information, read all these papers, and try to find their own candidate biomarker, which can be validated then. But we did not use this approach. We are using the discovery approach. So we want to find out what is not known. Where can we search for these markers? In oral cavity, we are lucky. We can non-invasively, easily open our patient's mouth and look at what is there. And we have great biofluids in our cavity. I put the first gingival crevicular fluid. The second is the saliva and the subgingival plaque, which can tell us about the bacterial content. And the later, we can also invasively collect some samples, like gingival tissue or the blood taken from our patients. And one can see that this is the gingival crevicular fluid, how we collect it, and the saliva, but simply spitting in a tube. And the gingival tissue can be collected during the surgery. So this is a wasted tissue. If you want to take it, you can take it during the surgery. But again, if it is a diagnostic tool, once you want to use in the dental chair, you don't want to do surgery to take a sample to test it. Why we want to use the proteomics? As I told you that the proteins are important functional workers of our body, but also use of this holistic approach, we can see all the proteins, or at least the most proteins in a given sample. So we are looking much larger, unbiased, and untargeted sets of proteins in that sense. And we are getting the whole picture. So we are not looking only one, we are trying to see the whole. And we are not biased, so we are not looking on the markers that have already been in the literature, and we are trying to make unexpected discoveries. And the one could say that this is the real biomarkers, because we have been looking at the others, they don't work. Maybe the new discoveries will tell us better. So I would like to give you the few examples where we applied what I have been telling you. And this is the images from a healthy patient, and this is images from clinical and radiographic images taken from patient which clinically diagnoses a generalized aggressive periodontitis. And the patient was only 21 years old, and her main complaint when patient came to the clinic was, my tooth is loose. So that's what it happens. Periodontitis is very silent disease, doesn't really cause pain, and the bleeding is maybe early indicator, but in the later stage it fades away. So our patients are only coming when the disease is really progressed and we cannot do much about that. If you look at it when surgically, when we open the site, you can see the amount of the tissue is lost is huge. So treating this is really it will take a time, and is not really predictable if our treatment will be effective. So therefore, would have been really great if we capture this patient in early as possible before reaching to this stage. And if you look at the age, the patient is only 21 years, so in the long term it will have a huge impact in the patient quality of life as well. And the one thing what I want to also to figure you out from this image is that periodontal disease is a site-specific disease. So therefore, the specific diagnosis is important. You can see here the next neighboring tooth. The bone here was not destroyed, whereas the molar, which are mostly effective ones in the aggressive forms, first effective ones at least, that was really destroyed. So if you want to diagnose this one, you will definitely need more site-specific information, because getting a general information won't help you to find this. On that sense, gingival clavicular fluid is really great aid to diagnosing periodontal disease at the site-specific. What it is, so you insert a small paper, which is commercially available filter papers, and for 30 seconds, non-invasive, very short, and once you insert, this is a histologic image of periodontitis in animal model, and you can see that once you insert this paper, everything was coming from the tissue, or from the tooth, or from the plaque, should be coming and inserted or immersed into this paper, and then we can go and measure it. So that's what how collected paper looks like. If we look at it closer under the microscope, you can see there is exudate. So the gingival clavicular fluid is a tissue exudate in disease and is considered a serum transudate in healthy condition. We can see this is not blood. It's really we have collected a material from the periodontal pocket. And if we want to understand the periodontal disease better, first we need to start what is health. That's the perfectly healthy periodontium. You need to know how it looks like. But the second stage after health is the gingivitis, so the gingival inflammation, which is confined only to gingiva, which is reversible. So the understanding gingival inflammation may help us to better understand periodontitis, which is the much later stage. Therefore, in research, we have been using, since 1965, what is called experimental gingivitis in humans. So basically, in this model, individuals are abstained from brushing their teeth over 21 days, so they don't brush at all. And that's how the gingiva looks like at the 21 days. So you can see the plaque accumulated, inflammation is, signs of inflammation are there, we have bleeding, we have swallowing, and probably the sites are also heated, so the temperature has increased in the gingiva. There are indications and the evidence in the literature. So what we did, we have collected gingival clavicular fluid from those patients where the inflammation was established, before establishing inflammation and after established inflammation. And we looked at the volume of the gingival clavicular fluid. So one can see that by induction of gingivitis in human, the gingival clavicular fluid volume was increasing, and which was also reflected in the total protein content. The proteins in that tissue, in that fluid was increasing. So that gives us a great material to work on. And we took that material and took this one into Proteomic platform. So we are using mass spectrometry. I'm not going in detail how we do that, but importance of this slide is to show you gingival clavicular fluid responding very well to plaque accumulation. The proteins is in every line here is a protein that's been identified and quantified in this fluid. And the numbers were around 200 and the regulated were down to the hundreds. What we can see that the first week of when the inflammation is setting in the first week, we see more downregulated protein. So the reddish the color, protein is reduced. Yellowish the color is protein is increased. And then the weeks are, when the weeks are going on, we can see that the proteome is dynamically increasing in their expression. So that the GCF is a dynamic proteome, it responds to bacterial accumulation. Therefore, we can use this information to understand the inflammation better. And we have now more than 100 candidates to validate in the next stage. So there are a lot of research to be done in that field. And then in the next one, what we have done, so that this time we are looking when patient have a disease. So the patient has already disease. In this case, it was aggressive periodontitis. And we are comparing this one with the healthy individual who doesn't have the disease, or at least clinically invisible disease. And when we look at the proteome, so again, we have identified 154 proteins. And between the health and disease, we had 47 proteins overlapping. So clearly, disease has its own proteome, health has its own proteome. And these proteins were coming from humans, so the tissues were producing, but also we have identified proteins coming from bacteria, which is logical. Crevice or the pocket is full of with the bacteria, and the viral and the yeast proteins, which were not much studied in the field, but they were there. And finding proteins is one way to look at the data and which proteins they are, what are their names. But another way of looking at this data was to understand what they do. So biologically, what is their function? So we have bioinformatic tools. We can take this data and look at already what is known. So what we have found that the proteins have many roles. So they are not only regulating inflammation, but they are involved in the signal transduction, they're involved in the metabolism and the cell organization and differentiation. What was interesting when we look at health versus disease, the inflammatory content, which is mostly studied parted in terms of protein expression in our field, was similar between health and disease in terms of numbers of protein identified. But there were qualitative differences between them. So when we look at deeper the data, what we have found, that we identified and quantified the proteins that were already known to the field, but we were also lucky to find novel proteins. That was the main aim of this approach, looking for the novel proteins. Indeed, annexin 1, which is a negative regulator of inflammation, was higher in health and not expressing disease. And whereas the L-plastin, another protein that produced by the leukocytes, then it was higher in disease but not present in health. So these were the two that we have identified as a novel and wanted to do more work on them. But there are, of course, other hundreds that are waiting for the validation. So once you identify the novel marker, or if it will become one day a biomarker, you need to go and validate in another cohort and take another sample type. So what we did, we have taken this time gingival tissue samples from the patient with the chronic and aggressive forms. If you remember, this data was coming from aggressive periodontitis, but what we could see that the expression of this protein, and gene expression, and the protein expression was present in the chronic and aggressive forms. So it is not only confined to aggressive periodontitis, but can be found in chronic periodontitis too. So this is kind of validation beyond the fishing experiments, what you get from the proteomics. So if we look at the numbers, we are not only one, of course, in the field who is doing proteomics. There are a lot of data is coming in terms of GCF, protein content of gingival crevicular fluid. And we have recently summarized this data to understand what happened in the field. So before 2010, when there was no proteomic word in the field, then we had candidate markers 65. When the proteomics were introduced to the field for biomarker search, and now these numbers are around 10 times much higher. So we have more than 600 proteins weights for validation as a potential biomarker. And some of those biomarkers in the era before proteomics have indeed reached the chair site and even FDA approved. For example, one of them was the Periogard, is an enzyme based. This was aspartate aminotransferase. This is the enzyme is released from the cell upon death. So if there is a tissue destruction, one will expect that this enzyme is increasing in the gingival crevicular fluid or in saliva. But what was the agony of such tests that no one was using them? So if you look at the publications were done with those tests were only very few. So it was not good enough to validate them as a clinical diagnostic tool. And also they had a lower, despite they were sensitive, but they had a lower specificity. So which is not good for a diagnostic tool. You want a specific and sensitive test. And MMP8 still in the market, and the inventor of the MMP8 periomarker, today we call it PerioSafe, yes. And Timo Sorsa, who is in the audience here, and Timo has been really validating this marker. So this is still in the market and is still under validation as far as I know. So that's the good one. So because the cardinal rule of a diagnostic tool is if no one uses and then test is not useful. So on that sense, if we want to get it, we want to get the dentist to start to using it and start to getting in their dental practices. So we have done enough discovery. Of course, the discovery is very exciting, but one day this has to reach onto the dental practice. And we have been, we have actually tested the public, not only the, how dentists respond to a diagnostic test. We had a chance in Zurich while we were at the University of Zurich to test the saliva as a potential diagnostic in oral diseases. And we had scientific days, public scientific days, which was called Scientifica, and we had a platform there to test the potential of saliva, how the public will respond. And this test was a BANA test, so this was one of those tests that came to chairside but doesn't exist. But we are using for our students. You can see here that many people queued up to do this test. So that was really a good sign. Not only the adults, but the children were signing up. So that's, and this gentleman in his suite didn't mind to spit. If he was given a blood test, possibly he wouldn't like because his shirt will get dirty. And our team here working in action, you can see our technician, Frein Osterwald, that I work over 7 years in Zurich. You can see she's saying, yes, good enough. We don't need much than this, so that you don't need a huge volume to study periodontal biomarker in saliva, for example. So not big, large quantities are needed. And after, this was back in 2012, and in 2015 we became a partner in an EU project called Horizon 2020, and the acronym of this project is Diagoras. So aim of this project was chairside, bedside diagnosis of oral and also respiratory tract infections and identification of antibiotic resistances for personalized monitoring and treatment. So that's the era now, is that where we are in the era for personalized monitoring and the treatment, where periodontal disease could get easily fitted in that. And what this device wants to do it, basically taking a saliva sample from individuals with periodontal disease or dental caries, and then putting them on this small disc, is called point-of-care, microfluidic disc, and they put in a machine, so this is a detector, and they get the data on a computer, and they tell us what is the diagnosis of disease and what is the prognosis of the disease. So this is under development, and we are involved, my main involvement in the periodontal diseases and the immunoassay, so that what we have gained information from our earlier work and also current work now is going to be incorporated onto this platform. Before closing my talk, and I would like to give you some piece of advice that how the way to move forward in this field. And firstly, accurate diagnosis, regardless of the periodontal disease, and absolutely necessary to develop effective treatment plan. So if you don't have a good diagnosis, if you don't have a correct diagnosis, you cannot treat your patient. So we are in the era of omics. You have seen genomics, transcriptomics, proteomics, and we are now talking about our patient as a whole system, not in a one protein, one gene, one DNA. So definitely what we have gained from these fields now, the time to apply this knowledge and not only assessing periodontal diseases on the clinical, only what we do by probing, basically measuring the clinically attachment loss and the bone loss. So we need to move away from tissue destruction model to the biologically defined disease. And you have seen there are, we are also involved in the one project, but there are also several labs are working on the point-of-care tests. So either for the patient use, so patient can do at home, or for the chair side. So there are a lot of progression in the field on that sense. But of course, as any discovery, there is a big gap when something is discovered when it reaches to the clinical practice. So it will take time to validate all these markers and to get them on a machine that can be used simply fast in the clinical practice. So there is a really long interval between the discovery and clinical application, and the clinical measurements will not be discarded if a new device and if new tool reaches the clinic. They will be still part of our clinical diagnosis. So my advice will be to you, please do not sell your periodontal probe you will be using, but be open to the new technologies that they are coming up in our field. And before closing my talk, I would like to acknowledge that the places I have worked, colleagues I have been collaborating, so the experimental gingivitis model that I have shown you, I have collaborated with the Professor Panos Papapanou from Columbia University, and my alma mater university is Ege University. I have a long-standing collaboration with them. And Barnes and London, I have worked while I was in London, and I did my PhD in there. And Eastman Dental Institute, which is part of UCL, and I have collaborated also translational mass spectrometry research group there, which was really nice. And the Diagoras platform that we are going to work together in the next 3 to 4 years. And thank you, all of you, for listening. And if you have any questions, you can come and ask me.